Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hassaballa.
All right, so hi everybody, this is Hassaballa. I am ecstatic to have Dr. Rob Bessler as my latest guest for the Great Minds in Medicine series. He was the founder of Sound Physicians in 2001, my employer, my current employer. He served as CEO and chairman for 22 years, and now he is the CEO of Honest Health. He is, in my mind, a mentor, a friend, a sage, one of really the great minds of medicine that I wanted to pick his brain and kind of get a sense of where healthcare has been. I think he's seen it. I think he's been a big part of the healthcare scene and where it's been and where it's going, and kind of help us chart what the future looks like. So welcome, Dr. Bessler. It's really an honor to have you.
Thanks, Hashem. Great to be with you as well.
Yeah, thank you so much. So let's just go right into it. You started one of the premier, and I'm biased, medical groups in the entire country, and it's grown to be something to be very proud of. Where kind of give me your sense of your perspective of where healthcare has been, and what you think about it.
Wow, that's a pretty broad way to start. I've been passionate since practicing emergency medicine in a community hospital after leaving, a big place like everybody else, where they trained and worked. And I was in Cleveland at the clinic, and when I started Sound, it was just trying to solve a problem, which was, nobody wanted to admit my patients, and those doctors that did, I kind of thought were practicing medicine 20 years ago when they trained, right? And so
right.
Had the intention to just go out and solve problems, get stuff done, and went out and got approval from the hospital CEO to back me to go hire 3 doctors. And, that's how we started. And 22 years later or whatever, it was a couple thousand physicians. And I think fundamentally, one thing didn't change, and it's been part of my life's work, is like, you want to build something that docs can be really proud of, the care being provided. And if you keep that at the center of what you do, you can win, right? Regardless. Like
right.
if docs are really proud of the care they're providing, they're not going to burn out, because we all work hard, right? But burnout doesn't happen because you work hard. It happens because you feel this lack of control or hope that you can do all the things you want in your life. And so that's been the focus, and continues to be, trying to focus on how do we make care that we can be really proud of, and how do we really improve quality and lower costs in every community we serve.
Mm-hmm.
Those fundamentals haven't changed. There's always curveballs with reimbursement and labor, the workforce, and external asteroids being thrown at us. But I don't think any of those fundamentals have changed. Patients still need great care. Our silver tsunami has occurred.
Right.
Unfortunately, we're getting closer to being in that group.
No doubt about it. Yeah. You mentioned burnout, and I kind of feel the same way, that if you love what you do, it's hard to burn out. And there's still a lot of burnout among our colleagues. And is it because just the work? You said it's not because you work hard. Is it because of the stupid stuff that we're made to do, or did some of us pick the wrong field, or what do you think?
I'm not like a expert on burnout by any means,
right?
But my experience is what I can share, having led thousands of physicians.
Yeah.
Is that burnout doesn't happen because you work hard. It happens when you don't feel empowered to fix what's broken, or you feel helpless and, a cog in the wheel, right?
Mhm.
And what we built, I'm very proud of at Sound, and what we're doing for our primary care doctors at Honest is taking control, right? And um, fixing the system, one patient at a time.
Right.
And that's very empowering. And, you know, I feel like burnout happens when you feel like you have to cut corners in one part of your life to do the other part, right? And that
Right.
that that becomes hard because that's not sustainable. If you feel like you're not able to give it all to your patients because you're got a lot going on at home, or you feel like you can't give it all to your patients or you can't give it all at home because of the demands of work, that's where it starts to feel like untenable,
Right.
and so every day working on how do we getting rid of stupid stuff, how do we make the system better, how do we set up a financial model that works. Those are the things that I've really focused on.
That's that's great. I think trying to develop it, I try to teach residents and students that try to develop those efficiencies so that you can, when your work is done, you're done and you don't have to take it home, and that you can separate and learn and without, like you said, cutting corners. That was one thing my teacher told me before I left training, is that don't ever cut corners, to try to get things done. And it is possible, but it can, it can be challenging. As far as from your perspective, is really healthcare going to be value only? Is there going to be any role for the traditional quote unquote way that we're doing it? I mean, I know it with a Sound, we tried to we were all in the value proposition with the federal government, and so, like, where do you see that going? I mean, obviously, I think Honest Health is in that space. Clearly, that you believe in that. But what's your perspective here as far as where our system is going? If you can, I mean, it's impossible to
Yeah,
predict.
yeah, no, I don't have a silver ball, but crystal ball. I think some fundamentals are that our country is running out of money for healthcare. We can't, every dollar additional percentage we spend on healthcare as a nation means we're spending less on something else, whether it's
Right,
other things we value in society. There's tons of waste. Um, Patients demand better. Obviously, outcomes, and all the stats around that relative to
mhm,
other countries, we have opportunity. People still come to the US from all over the world when they are sick, though. And there's a reason for that, because we have great clinicians, we have great facilities, we have great technology. It's just, is it affordable at scale? There's plenty of health systems, you work in them, it maybe not directly, but serve and partner. There's plenty of health system executives that still say there's gold in those hills of fee for service,
hmm.
and are going to stick to their knitting in that regard. Um, it's our belief that the consumer, whether it's a Medicare patient or a government or or an employer, needs solutions, right, to
Right,
the cost problem. And both at Sound and my current role as the employer, you kind of saw both sides of it, right? At
right,
Sound, I don't know, we were responsible for the funding for the care for 15,000 beneficiaries, right? So if you think about
hmm,
your employees plus their families, and you know it, it, you can't just keep costs can't keep going up, and
right,
and what are you going to do about it? And so I think the forces are aligned there. It's going to be, the CMS has said by 2030 everything's going to be through value. I don't know if that's the timeline that's going to work.
hmm,
But I'm betting that the model for primary care of just trying to turn the conveyor belt up faster and faster, see more patients is completely unsustainable.
Right.
And that the quicker we can move um, the real world of American medicine, which is not, these little pockets, but, out in, you know, every town in America that has just general primary care, like how do we get them towards getting paid for keeping people healthy?
Yeah.
The sooner the better. That's good for patients. It's good for our country. And frankly, it's good for the provider. Like it's a more sustainable model. I don't, we have 1,500 primary care providers that we partner with today. And, they don't need to have the patient come in for that urinary tract infection or,
Yeah.
they can handle it by phone and they're doing fine, right? They can,
Right.
if the patient is homebound, we can send a nurse practitioner into the home to see that high risk patient. Again, everything we do, we want to make sure that the providers are really proud of the care being provided, and that's when we know we're winning.
Right. How much of that is on the patient? I see people that just don't do what they're supposed to do. It's their chronic disease management is hard. I mean, I shudder, to think of, God forbid, I get diabetes or heart failure or peripheral vascular disease. I mean, they're tough diseases to manage as a physician. It's even tougher as a patient. And you have a patient that doesn't want to take diuretic because they're up all night going to the bathroom, and that
Right.
disrupts their sleep. And I mean, but it seems like I, as the clinician, is held responsible for that, right? Where's the
I think
balance?
you
Like,
see.
where's the balance?
Yeah, I'm not sure how to answer that other than obviously you're seeing as a critical care physician the best trained docs in the hospital taking care of the sickest patients, right? You're
Right.
seeing you're at the tip of the spear.
Right.
I kind of think about one of the holy grails in this line of work is patient engagement and figuring out how to meet patients where they are.
Right.
And you don't have to make, you don't have to be perfect. You don't have to make perfect the enemy of good here. And
True.
so in our world, actuarially, 3 or 4% of the senior patients are driving a vast majority of the expense and utilize the vast majority of the resources. So it's about working smarter on those patients. How do we identify them? How do we engage them? How do we meet them where they are, whether they're in the home or in the clinic? How do we wrap services around them that they see as valuable, as well as the provider and science supports, right?
Yeah.
And
Yeah.
and we're not going to be perfect, but at a population level, you don't need to be perfect. You just got to keep getting better every day,
Right.
you know. And I think that's how you keep your morale up when you see the outlier case. I think it's hard in your world because, it's never good when a patient shows up in the ICU. It's never
That's true.
it's never
Nobody
yeah.
wants to see me.
Well, it's just, I guess it's a good outcome if they've survived to be in the ICU in some instances, but
Right. Right.
you're seeing all the challenges.
Yeah. No. And we're forced to be palliative care docs every day.
Yeah.
I mean, I had discussions last night with a patient who he didn't want to go to the doctor, didn't want to get his angiogram, and then he suffered cardiac arrest. And
Right.
I told the family, he was telling us what he wants. He's giving
Yeah.
us, we're just not listening. And I'm forced to have that conversation
And
literally
you're
every
doing it
single
in the
day.
wrong, and right, you're doing it
In the wrong place.
obviously in my current organization, we want to be having those important conversations early and often,
Yeah,
right? And
100%.
and part of that's risk stratification. How many diagnoses do they have? Are we talking to those right patients, right?
Right.
And I think it's just for our healthcare system to become even more important, right? The number of patients over the age of 85 today dramatically higher than 10 years ago.
Hmm.
And these are the right conversations. I think you
Right.
were at Sound when I bought everybody for the holidays in the whole organization, Being Mortal. I wanted
Yes.
everybody to read the book,
Yes.
and couple thousand copies later really changed the conversation within our own organization, right?
Oh, absolutely. I mean, and it's so important. And I had a podcast about that, saying as my last one, getting your living will done, because otherwise you're liable to get care that's not consistent with
Yeah,
what you
then
want.
Dr. Hassaballa is the one deciding, huh?
Well, no, it's the state of Illinois, maybe
Yeah,
the
right.
one deciding, right?
At,
Which is why I had a crazy case where
at
that was
3 a.m.
at 3 a.m. Precisely,
Right.
precisely. Have we been victims of our own success? You said the proportion of 85-year-olds is the highest it's ever been. Are we victims of our are we victims of our own success here, where we've done such a good job to provide longevity? This was never foreseen when Medicare was first created. It was never foreseen that people would live into their 80s. Same thing with Social
Yeah.
Security.
Well, I
Do
think
we
for
have to
sure.
ration care? Are we gonna have to ration care? I hate to use that word, but
Well, I
like,
would say it different. I would ask the question a little differently, which is, our technology is far out ahead of our knowledge of what to do with the information.
okay,
Um, the classic challenge today is mammography, right?
right,
Our ability to find the smallest possible things, and the continued controversy every year on what to do with those findings. Obviously, we want great care for women and for all of us, and so um, I think that's one of the challenges today. Is every time a new technology comes out and we want to use it to get the best care, it costs money, and
hmm,
where's that money coming from? Um, it's not like there's an ROI of, well, if we do this, more people are in the workforce, and then there's more funding with more tax dollars. It's not that clear, right? Where are
right,
we gonna
right,
where are we gonna get the funding?
yeah,
And that's what leads to the challenge of, it's got to be budget neutral on funding. And so if you're going to add this, you got to subtract here, and then somebody's always upset. And so to me, the solution is you got to get upstream and get rid of the waste. We have providers, our current model, our providers do a lot better financially than they would do in fee for service. They're not working harder. And
really.
and the way to do that is you got to get upstream and get rid of the waste.
Is there a lot of waste? Uh,
I'm not, you don't need me to tell you that, but there's so much waste in healthcare. Um, we see it every day. You know,
yeah,
uh, I'll just give you an example. We identified within one of our markets in a use of one eye drop type by the large ophthalmology group
hmm,
that was costing tens of thousands of dollars per patient. And it's crazy, right? Like,
right,
with no better outcomes, but somehow it got instituted. And we're those are like simple opportunities on waste.
yeah,
um there's a reason when my kids were in high school, their car insurance was crazy high, right? They're the
yeah,
most likely ones to get in an accident. Well, every time a patient gets discharged from a hospital, it's the same concept. They're the most likely to be readmitted,
yeah,
right? So there's a ton
yeah,
of waste by not being all over those patients, getting them into the clinic within 3 days of discharge, making sure their meds are reconciled, making sure they understand what to do instead of calling 911. Um, what's going on today is why I think, why I'm so energized about what we're doing now
hmm,
at Honest is, you know, hospitals lose money on every medical Medicare admission.
Yeah. Yeah.
Primary care docs are subsidized by health systems to over $200,000 per doctor.
Okay. Yeah.
And most hospitals are full. So these aren't the patients that hospitals need to be successful. They lose money on, and they're clogging up the beds. So what we're focused on is not lowering how many orthopedic procedures happen. Like, we don't really have the influence there. We just want to focus on the non-value care that's happening. And of course it's good care maybe that when they get readmitted, but they shouldn't get readmitted, right? We should be
Yeah.
preventing them before they get readmitted.
Right.
We should be identifying, class 2 heart failure before it's class 3, so that we're upstream of it and treating it, earlier, right? And these are the types of things that we can really get after in a meaningful way.
It seems hard work though it's very resource intensive, and it doesn't seem to me, and correct me if I'm wrong, that there's a lot of, or many that want to invest those, because the benefits are way downstream, and organizations are looking at the next quarter.
Yeah.
Right. I mean,
so that's interesting. So what we've done to solve that is we're taking all the downside risk for our health system partners. We're paying incentives monthly to the providers for the things that move the needle. So we're putting new money in the hands of the providers in real time, and not waiting 12 or 18 months till the funding gets reconciled. And those are the types of things we have to do to drive change faster.
Interesting.
Right?
Interesting.
And I think, hospitals in particular are reluctant to take risk, right? They have such low margins today.
Right.
But in order to make this leap, we've been able to do it with health systems, by, guaranteeing their downside protection.
Oh, wow. So then there'll be more willing partners.
Yeah, that's just upside for them.
Wow. So what do you get? What do you get for? What do you get it? What's in it for you, as the medical group?
Yeah. So Honest Health is focused on enabling primary care physicians in a transformation to value. So we're focused on all seniors, both fee-for-service, Medicare, and Medicare Advantage. And we want one process of care for all seniors in their practice. We embed the processes, the technology, the training, and all of the infrastructure needed. We wrap the services around their patients. If they have services already, we don't replicate them. We don't fix what's not broken. And we're doing care management. We're doing in-home visits when needed, and we're taking full risk on the premium, and we're reconciling with either the federal government or the Medicare Advantage plan on the total cost of care, and splitting the savings between us and our partner, either the primary care physician directly or the health system.
Okay. Yeah. Do you foresee a future without private? I mean, you're in the business with private medical insurance. Do you foresee a future without private medical insurance, or is that all? Because I'm a physician advisor, and I see the other side. I was doing appeals this morning where they come in and they say, "Oh, the patient didn't have it wasn't a COPD exacerbation. They had COVID, and so you owe us $3,000." Like, I see I see the other side of that, and it's hard not to get frustrated from my perspective, right? Because I just don't see how you could to make a profit. Your revenue has to be more than your cost. So how do you reduce cost? Is by I'll say it, denying care.
Yeah.
But I'm
Well, I
very
think,
like, I see the bad, like see the one side of it.
yeah, I don't, I mean, your first question was, do you see a world where there's not private insurance? No, I don't
Mhm.
think the American way would ultimately allow for lack of choice, right?
That's just our that's our culture, right?
and the consequences of a single payer just means less reimbursement and more socialism. And I don't think our country ultimately, at least 50% of the country, and I would say a lot of most moderates on both sides of the aisle wouldn't support that,
Yeah,
you
yeah.
know. So I'm not really worried about a single payer model. Um, I think denial management is a big problem. I think the only way to, well, one way to solve for that is to transfer the risk back to the health system. So
Hmm.
they're great. So they're getting upstream and they're not in the fee for service. So Medicare Advantage at best, like might pay 100% of Medicare to a
Hmm.
hospital, but because of the way the denial's working, lots of health systems, I've talked to many, national system CEOs, and they'll tell you that, they're collecting 82 to 85% of the dollar in MA right now. And that's why there's a lot of talk out there about dropping Medicare Advantage. I don't think ultimately they will, because there's a trend towards more and more patients going to Medicare Advantage. And what's their alternative payment right now? It's Medicaid's 20 to 30% of their volume,
Yeah,
and so who are they going to care for? So I think that's not the answer. And well, we're betting on the answer being, well, you got to be in the business of keeping people healthy and doing care at the right time
right.
and getting upstream on the premium dollar, right?
Yep.
And so we're optimistic. We're seeing a lot of momentum there, and that's the way out of this. And then you're not really in the denials. You're not really worried about the denials as much as you're worried about the failure of an unnecessary admission.
Right. Right. And is so, and I was talking with Rob Zipper a couple weeks ago about, I feel like it's always the savings seem to be, and of course that's why I wanted your perspective. The savings seem to be on the head of the clinician all the time. Like we're, if I still remember, we're only 4% of the healthcare dollar. And it seems like every time the finger's pointed at us as the clinician and the savings keep coming from us. Is that a misperception? I mean, you're talking about an eye drop that's 10,000, thousands of
Yeah, yeah,
dollars. But I'm the one that's making too much money as the
yeah.
clinician.
I think I think it depends on your lens, right?
Right.
I think the regulatory challenge in the physician space is this idea of, if we're going to spend more in one place, we have to spend less in another,
Yeah. Yeah.
right?
It's a zero sum game.
Right, and the fact that there isn't one unified physician voice, but lots of different physician organizations fighting for the same dollar
Hmm.
is, you know, a, a challenge that's unique within healthcare spend, versus if you look at drug lobbying or any hospital lobbying. They're not all, they're all aligned, right? They have one,
Yeah.
or there's a perception more of one voice. um you know uh so I would say that's part of it.
Hmm.
um but I think all parts of the system are getting squeezed, and it's just, I think there's going to be more pain, for both health systems, providers, and obviously the plans this year are feeling a fair amount of pain,
Right.
as well.
Yeah. I have a family member who's works for Humana, and he's distressed over the offerings that they're going to have and his job is to sell them, and he's nervous about selling them because they're just not as generous as they used to be because of the
Yeah.
squeeze, like you said.
I mean, GLP-1s is a perfect example, right? So,
Yeah.
we think they're great for lots of different reasons for patients. They cost a lot of money, and you add them to the system. Well, where's that funding come from? I mean, you're hoping long term it saves money for our nation because there's less obesity, diabetes, renal failure, all these things. But
Right.
like, that's not a short-term ROI to find new money in the system. And
Yeah.
so a plan, you know, we have plenty of plans dropping coverage because they don't know what to do. Like, where's the money going to come from?
That's interesting. That's that's a great question. Where is the money going to come from? It seems like ultimately
My bet is the money's going to come from getting rid of waste. That's
getting
like,
rid of waste.
yeah, high value care. And
How can I get
value-based.
rid of waste as a critical care doc?
It's a great
Or is it too
question.
late? Or is it too late when it's free?
I think, you know, it's not a popular topic. But you brought it up earlier. Like, it's making sure the right patients are getting the care.
Mm-hmm.
And, you know, I think you've said it in other words, like, life is a terminal illness, and you know, like, we all are going to pass, and making sure families have those difficult conversations in advance. I mean, we see it every day, right?
Yeah.
I had it as a practicing ER doc on the front end, you know, you have like a moment to make a decision when the family's had, you know, years to talk about it and they haven't. So
Right.
I don't know if that's something you specifically can do on waste, other than continue to lead with your heart and get families to, you know, do the hard things that they do, and with your input and guidance. But that's like one patient at a time stuff, right? I think,
Right.
but you know, that doesn't solve the problem one patient at a time, right? But I think it's, you know, advocacy around end of life discussions, making sure the primary care doctors are having them with their patients,
Mm-hmm.
making sure that we identify through data and which patients we should be having these conversations with,
Yeah.
and you know, respecting their wishes appropriate, and you know, is key.
Yeah, I agree. And I think if more of us do it, I mean, I think I see it as just providing care consistent with values and preferences, not crossing my patient's red lines. And if you look at it from a population perspective, maybe that is getting rid of, I hate to use the word waste, but why, if someone doesn't want to be kept alive on machines, then why do we do it? We
Yeah, I
shouldn't
mean,
do it.
I mean, it's not great at the individual patient level to talk about this, right? Because we've all
Right.
had family members there. But if we think about where we spend money in Medicare, look at the last 6 months of life.
Right.
And if you, my belief is, if you really, I don't know how to solve for that as a nation,
Mm-hmm.
because we have a diverse set of beliefs and we want to respect it. You know, it's not the American way to set, you know, restrict people's access and things like that. But to me, that's, you know, why did Willie Sutton rob banks? Where the money is, you know, like, where should you focus? It's like that last 6 months of life is a huge opportunity.
Yeah. 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 I mean, it's pretty daunting, and I'm glad there are visionaries like you trying to solve the problem. I think, which is why,
Yeah.
again, I wanted to talk to you, because your perspective is so
Yeah. I mean, like, right.
so great.
We know that patients that go on hospice live longer, have a higher
Which is
quality of
ironic.
life, right? Have a higher quality of life, um, and cost less, right? And
Mhm.
so that's a lever that I think still is very underutilized
Yeah, and
as a country.
palliative. My ideal unit would have a palliative care doc or APP in every single ICU. I just can't find them.
Right.
There aren't enough of them. And then we're not allowed as intensivists to be deputized as palliative care doctors,
Mm,
right? We have to go
interesting.
through training, right? But
Right.
I'm doing palliative care literally every day of the week.
Yeah.
And yet I'm not allowed to be, I'm a, off label,
Understood. Other
Uh,
duties as assigned.
that's precisely it. That's precisely it. Um, what advice to my daughter? I told you before we went on air. Our daughter is she started medical school this year. What advice do you have for people entering our field right now?
That's well, the first is like people ask me all the time, would you still recommend it? And I'd say absolutely, without a doubt. I think there's very few careers where you can spend your life helping people, using your brain every day, and make a good living. Like what a gift it is. I think those that are deep in the trenches, facing lack of control and feeling like they're a cog on a wheel and don't feel they have a voice or don't have a sense of control, tend sometimes feel otherwise, or had it differently back in the day, quote unquote.
Yeah,
Um, so I recognize there's other views, but I still feel like what a privilege and gift it is to care for people. And as you know, the thank you get is priceless, right? And
it is. I got
and
a card yesterday,
yeah,
literally.
it's awesome. It's just awesome. So I think you got to go to it for the right reasons. Um, I think you have to, I think what's undervalued going in is leadership skills. I think every
Mhm,
physician every day is a leader, right? They're leading a
mhm.
team, they're leading a care team, they're leading families, they're leading
Yeah,
peers. And so, I would like there to be more um, education and training on those sort of skills that it takes, whether it's learning how to work with others, teamwork, learning
yeah,
how to communicate effectively. Um, those are soft skills that are super valuable, right? Like the clinical
yeah.
care, as you and I have both talked about before, the clinical care is the easy part 10 years after being out of training.
Right.
The hard,
Yep.
this job would be easy if it wasn't for people, right? Like this is hard because they're humans and we have to have those challenging conversations.
Yeah.
So that's part of what I would say to somebody going in is where you're going to pick up those skills. And then obviously I'm biased because I think we don't do enough in our training on teaching providers about the macro picture of healthcare. And you
Right.
know, we have a value-based care university at Honest that I think would be super valuable training. We're working with some academic systems now, and one of the things they see as a byproduct and benefit of working with us, because they all employ lots of primary care docs, but
Hmm.
is they all have residents and medical students, and the same stuff we're teaching the primary care docs could be taught, you know, much earlier as well. To
Right.
understand medical economics and the U.S. healthcare system.
I have forgot to ask this. Is this HMO 3.0 or is this different?
This is meeting doctors where they are to help them transform their practice and get paid for the value they're creating versus the number of patients they see.
Right. Which is more satisfying, right? And I think you've seen that, right? You've seen that. That's way more satisfying. That you're really helping to heal, and you're being remunerated to help heal, rather than
Heal, well, that's heal or keep people healthy. Like
keep
I
people
rather not
healthy.
heal. I,
Oh, fair
I'd
enough.
rather
Fair enough.
like they don't have to be sick. Like we'd rather prevent and let them, you know, live a full and productive life, and obviously care for the sick, but um, help keep people as healthy as possible.
So that's really a fundamental shaping of what it means to be a physician, right? I mean, is this what we were supposed to do all along?
I guess it depends on your specialty.
True. That's right. That's right.
We still need critical care docs.
Thank
Still
God
need
for that.
we still need ER docs
Yep.
and
Yep.
hospitalists and all the rest.
That's true. That's true. Well, Dr. Bessler, it's been an honor and a pleasure to have you on the podcast. I think your wisdom is very timely. I'm glad that you are at the helm of what needs to be done in the healthcare system and in our country. And it's really good to see you. And thanks so much for all you do.
Thanks. Pleasure to be with you, Hashem.
Thank you.
Take care.
Thank you for watching. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.